So we have our first speaker, Dr. Venkatraman from Singapore, and he will give us two examples, two case studies for translational applications of nanomedicine in glaucoma. Please, Mr. Venkatraman.
Thank you. Let me first thank the organizers for this invitation, particularly Dr. Leffler and Dr. Baloch, for inviting me to this conference. Here's a chance for us to talk about experiences in translating nanomedicine for non-cancer applications, particularly for ocular disease, ophthalmic disease. We became interested in it's not working.
Maybe you try the
may you have to turn it on the right side, or left?
Okay.
Okay.
Yep, thank you.
You're welcome.
So we asked the question, why is nanomedicine limited to cancer chemotherapy, or the focus of the research in nanomedicine has been predominantly in cancer chemotherapy, and why aren't other areas being explored? So it looks as though the reason, there are a couple of reasons. One is that, first of all, the nano size is important in biodistribution, as you heard this morning at the earlier session, and that has a favorable benefit for cancer chemotherapy. And the second reason is that other applications generally require sustained release or control over the release of the bioactive molecule, which has been very difficult to achieve with nanoparticles. In fact, if you see the picture here, which was generated by an article in Nanomedicine a couple of years, 3 years ago, you can see that the field is dominated by a lot of product development in the area of intravenously injected nanoparticles, which deals predominantly with cancer chemotherapy. There are very few sustained release products approved, none at all in the ophthalmic space. So this is the point that we sought to address with some of our work in addressing the need for nanomedicine ocular therapeutics. So the question is nanomedicine useful for non-cancer therapeutic, especially for ocular disease? The answer is that if cellular penetration is an important characteristic of the nanomedicine, or if optical clarity is needed. So the smaller the size of the particle, the less light it scatters. So in the eye, this is an important attribute. But in addition to these characteristics, we also need to have fairly high drug loading and control over how this drug comes out of the nanoparticle, protection of the cargo that is encapsulated in the nanoparticle. That is very important for many applications, as I will show today. Unfortunately, sustained release or obtaining extended periods of release beyond a few days from nanoparticles is much more difficult than from microparticles. There are products using microparticles that can deliver drugs for over a few months, but none in nanomedicine for nanoparticles. The reason, of course, is that the surface to volume ratio is much higher and the diffusion path length for the drugs is much smaller. In fact, in the first approved nanomedicine product, Doxil, which I worked on, controls the release of the drug by loading the doxorubicin in the core of the liposome to such an extent that it's actually crystallized. And in fact, the efflux of the drug is controlled by the dissolution kinetics of the crystals rather than by diffusion. That helps it to avoid being prematurely released while it's circulating in the bloodstream. But that's only for a couple of days or maybe 3 or 4 days at the most. In fact, if you look at all the approved liposomal products, you will see that none of them have control over the release for more than a few days. In fact, the only one that has control over release over 5 days is in fact a micron-sized particle, liposome, not a nanoliposome. Okay, so how does this help with eye disease? So this is a snapshot of the prevalence of various eye diseases globally. And as you can see here, cataract by far dominates the prevalence, followed closely by glaucoma. Okay, And these two are the major causes for blindness. Fortunately, cataract is reversible, as you heard from Professor Reisamer's talk yesterday, by the implantation of intraocular lenses. Glaucoma currently is not. It can only be managed or prevented from becoming worse. So for the eye application, we looked at whether or not we could use nanoparticles to control intraocular pressure, which is a risk factor for glaucoma development. That was one of the major areas we were interested in. We were also interested in whether or not we can use anti-rejection medication for corneal transplants, as well as nanocarriers that can deliver for long periods for uveitis. Another project we had on was to use siRNA against scar tissue formation in the eye following glaucoma filtration surgery. So these are the two things I'll be talking about today: nanomedicine for glaucoma, and also nanomedicine or siRNA delivery system for prevention of scar tissue formation. The medical need is clearly defined here. By the way, I should mention that I work very closely with two ophthalmologists at the Singapore Eye Research Institute, Dr. Tina Wong and Dr. Donald Tan. And together we define the medical need, which is shown here. Currently, the only treatment for glaucoma are eye drops that contain different drugs. There are patient compliance issues with this. There are side effects of the eye drops. Many of the older patients forget to take the eye drops on a daily basis, and this can lead to uncontrolled IOP, intraocular pressure, that can lead to damage of the optic nerve. There is also a problem of bioavailability. Anything that is topically administered on the outside of the eye is only about 5% at best gets across to the receptor sites inside the eye. Rest of the drug is wasted and cleared away. So sustained delivery using topical eye drops is almost impossible. If you can solve the problem of sustained delivery, we can also solve the problems listed here of patient compliance. However, in discussion with the ophthalmologist, the minimum period of action or duration of action should be around 3 months. That is imposing a huge demand on controlled release of the drug. So a single administration, which lasts 2 to 3 months, is required for the patients to accept this mode of treatment. 3 months is ideal because every 3 months the patients do visit their doctors again for a checkup, so the second administration can be done at that visit. Okay. So there have been attempts to improve the duration of action of existing glaucoma drugs. One way is to improve or increase the viscosity of the eye drop. That doesn't really work well. Maximum 1 hour of duration of action is achievable. There is also contact lenses containing drugs that can be put on the eye. This also suffers from poor bioavailability because it's a topical means of administration. So the maximum duration of action you can achieve is about 2 weeks. There is also wastage of drugs and so on. There is also vision restriction because the amount of drug that you need to load into the contact lens to get the effect is very, very large, and it exceeds the solubility limit of the drug in the polymer. So you have restricted vision. People have also worked on solid implants, small pellets that can be fairly minimally invasively inserted into the eye that can deliver for long periods of time, but it does carry with it some degree of patient risk and discomfort. So what we wanted to do was really use a subconjunctival injection of a liquid nanomedicine. This is optically clear. The patient really does not feel any discomfort because it's a fairly painless procedure. But the challenge is to release the drug over several months and keeping the suspension or the liquid material stable over several years. So we use liposomes, which have been used in nanomedicine quite a bit over the last few years. Typically, the control of release of drugs from liposomes is modulated by the use of cholesterol in the bilayer. That stiffens up the liposome and reduces diffusional efflux. We did not want to do this. We wanted to use a totally different approach to sustaining the release. The drug we used was latanoprost, whose structure is shown here. We wanted to embed it in the bilayer and control its release over several weeks and months. The question really is, how much can we load into this bilayer without disrupting the self-assembled structure of the liposome? That's a very important consideration for reproducible drug release kinetics. For most drugs, we need at least 10% by weight of the liposome to be loaded with the drug to sustain the action over several months. This is not trivial. Loading and not affecting self-assembly at such high levels is very, very difficult to do. We tried a number of liposomal candidates and achieved up to about 16% loading in many of these. So these are enough to have efficacy of action over a few months without disrupting the... in comparison, the doxil liposomal drug loading is about 12%, okay? Just as a reference point. It's also important to entrap most of the drug in the bilayer, not have too much free drug floating around. That leads to wastage of drug also. And that we were able to do with many of these liposomal molecules, particularly with ECPC. That's a liposome that we ended up with our studies. The in vitro release profile looks something like this. Release is sustained over about 45 days. But to our surprise, when we went into rabbit studies, the efficacy of action was much longer. So you can see here, this is a plot of the reduction in IOP versus time. Okay? The rabbits are given a daily eye drop, and that lowers the IOP by a certain amount that is shown here. They're also given the subconjunctival injection on day 0, and a single injection lasts for up to 90 days. So this was surprising to us, but nevertheless, that is a reproducible result. With this data, we are actually, I'll also show you pictures of the rabbit eye following the injection. There is a small bleb that is formed immediately, which resolves within 24 hours. And then subsequently, as you can see, there is hardly any redness noticeable in the eye over time. Okay, so why does this work actually as well as it does? We believe the reason is that we now have partition-controlled release rather than diffusion-controlled release. What that means, in a simple sense, is that the drug likes to reside in the bilayer rather than in the surrounding liquid. And if you inject into space that has limited volume of liquid, you can achieve controlled release over long periods of time. Okay? We did isothermal calorimetric studies. I will not go into all the details. But there are specific interactions between the drug and the lipid molecule, pi-pi interactions and polar interactions, which helps to stabilize the drug inside the bilayer and control its release over long periods of time. Okay? And pictorially, that's what is shown here, the drug residing in the lipid bilayer. And you can see also the TEM, of the liposomes containing the drug. They are nearly spherical or almost completely spherical. Okay, with the rabbit data, we were able to get permission to conduct a very small human study using this ECPC formulation. We enrolled, or the ophthalmologist enrolled 6 patients, 5 males and 1 female of mixed ethnicity, and we studied both the safety and efficacy of a subconjunctival injection compared to eye drops. And this is sort of the long and short of the data here. As you can see, the eye drops, which are shown as the red bars, lower the intraocular pressure somewhat. Okay? But in comparison, the subconjunctival injection lowers it much more, especially in the early stages. And the effect is sustained over 3 months. Okay? Patient tolerance to the injection was very good. There was hardly any discomfort reported. In fact, these studies have built-in controls. So one eye is treated with the eye drop and the other eye is treated with the subconjunctival injection. And in many cases, you could see the difference in the redness levels of the 2 eyes. The topically administered latanoprost caused much more irritation in the eye than the subconjunctivally injected one. Okay, so just to give you an idea of how long it took us to get from concept concept to the first-in-man trials. This is a snapshot from Etheridge et al. On how long typically it takes to get to first-in-man trials. So the preclinical phase for typical nanomedicinal products, whether it's diagnostics or therapeutics, is between 7 to 20 years. So the shorter time frame probably applies to diagnostics, especially ex vivo diagnostics, and the longer time frame applies to in vivo therapeutics. So that's the average time taken to develop something and get into the clinic. What it took us was about 5 years from start to finish. This again is because we worked very closely with ophthalmologists from day one. All right, and the results of the first-in-man trial was enough to convince angel investors to invest in a company called Peregrine Medical, which is now conducting the phase 2b trials in the US. Okay, one picture of our translation efforts. The second one, which I'll quickly go through in the interest of time, is really delivering siRNA into the eye, also subconjunctivally. The particular problem we addressed is the blockage that occurs after filtration surgery. So people with severe cases of glaucoma will have to undergo filtration surgery. And then the channel that is opened up, unfortunately, becomes blocked again due to the scar tissue formation. And the only drug that is currently used is 5-FU, which is dabbed on at the time of the surgical procedure, but it's not very ideal. It's non-selective. It kills a lot of other cells in addition to the fibroblasts that are involved in the scar tissue formation. We were able to use an siRNA against this protein called SPARC, anti-SPARC siRNA. The nanoparticle that we used here was very different from liposomes. Liposomes involve the use of organic solvents, and that is not particularly useful for siRNA incorporation. So what we used instead was a layer-by-layer polyelectrolyte deposition approach, in which one of the layers happens to be the anti-SPARC siRNA. So loading multiple layers of this into a hydroxyapatite nanoparticle core, we were able to get sufficient loading, and also we are able to impart a positive charge to the outside layer of this nanoparticle, which is important for cellular penetration. All right, I'll not go into the details of the animal study in the interest of time. I'll just say that day 7 and day 14, we were able to see suppression of SPARC production as well as collagen production, important parameters for looking at scar tissue formation. And the trend is maintained at day 14. And this is enough for us to now convince the Singapore authorities to conduct a small first-in-man trial for patients undergoing this trabeculectomy procedure. All right, so let me conclude with a summary slide here, which says that we have successfully completed a first-in-human phase 1b trial in about 5 years' time from start to finish. We believe this is one of the first reported instances of nanomedicine being able to achieve sustained efficacy of action for more than a month. And that really opens up the door to other applications. And some of those applications within the eye I have listed down below: diabetic retinopathy, uveitis, IOL for cataracts, and so on. Lipolat provides matching performance of eye drops. Lipolat is the trade name given to this particular product containing the latanoprost drug. And we hope that it will lead to significant and better changes in medical management of glaucoma. Okay, so thank you very much for your attention, and I'll be happy to answer questions.
Thank you very much. So for the sake of time, there is time for one question.
Yeah.
Thank you. Very interesting work.
Thank you.
Regarding the mRNA delivery, which type of collagen you suppressed?
Oh.
You use mRNA to suppress collagen expression.
I'm not sure, but I think it's collagen 1, but I'm not sure.
Okay.
I can confirm it for you.
Okay, then thank you very much. We go to our next speaker now.